Welcome, everybody. Thank you so much for joining us for Mission Hospice and Home Care's Community Conversation Series. I'm so pleased to have Hank Dunn, who is a chaplain and a wonderful author. Hank attended one of our earlier Take Charge trainings about advanced care planning. When I was looking at our list of attendees, I kept thinking, boy, that name is so familiar. Do I know him as a volunteer? And then I realized, oh my gosh, we actually offer his beautiful book, Hard Choices for Loving People, to both our volunteers at the bedside when they finish their training. And we've just recently, at the beginning of our year, trained a group of community ambassadors. Some of them are here with us today to offer trainings for advanced care planning in our community, and we also gift this book. So after a little bit of a laugh on my part, Hank agreed to join us today to talk with us about the work that he's been doing and about the discoveries he's made working with families and patients around the things that matter most to them. So I'm just so grateful to have you with us today, Hank. If there's anything that you would like to say, I just will say to everybody here that my name is Susan Barber, and I am the Community Education Manager at Mission Hospice and Home Care. And for those that don't live in the sort of Bay Area in Northern California, we are a small, non-affiliated, meaning that we are not attached to any large healthcare system or hospital system. Our hospice was founded in 1979 by two very wonderful women in our community, one of whom became our first patient. She wanted a better way to die than being in the hospital. And the second founder, Helen, died in 2014 at the age of 103, having witnessed hundreds and thousands of people being cared for since 1979. Our community education program has been going since 2015. And in addition to our community conversations, we offer a weekly death cafe and about 2 other community conversations a month. So you all will be getting emails about that on Monday. And I just also want to say to those of you that are joining from Northern California and affected by not just the pandemic that we're all affected by the fires and the dislocation of so many people, just that you are all in our hearts at Mission Hospice. And thank you for being with us. Hank did say, I sent out a handout that Hank included, that Hank sent to me, and I hope that all of you have gotten that. I will also send that on the evaluation and resource page that will be sent out to you later today. If you are able to complete the evaluation in particular, that's so helpful to us and organizing our programming for next year. So having said everything I need to say, Hank, thank you so much for being with us, and please go ahead and you can introduce yourself.
Well, thank you, Susan, for having me, and glad to be with your folks. Yeah, Susan asked me if I could say a little bit about myself, how I got into this, and why it means so much to me. Actually, I was out of work. I needed a job. This was in 1983, and I had the opportunity to be a half-time chaplain at a nursing home. It was a 200-bed, private, family-owned, standalone nursing home in Fairfax, Virginia. So I interviewed and I said, well, I think I could try this. And so I did. And after 6 months, I was really liking the work so much. I asked if they could make it a full-time job, and they said, yes, we can. And so that was 83, 84. Virginia had just passed a Natural Death Act. The nursing home started a ethics committee. And in that, with the ethics committee, we asked the questions, how can we help our residents, their families, with these end-of-life decisions? They now had a living will that was on the statute of Virginia. So the ethics committee said, we're going to tell everybody, all the residents and their families about this. And Hank, we want you to do that. And I knew nothing or very little. Now I'd only been working for 6 months in it. So I just started reading everything I could. And the nurses just helped me tremendously of how to talk about end-of-life decisions. So after doing it for a couple of years, I said to the ethics committee, I said, why don't we write this down, put a little pamphlet, and we can hand it out. And the ethics committee to the person said, oh, no, don't you dare do that. We don't want it in writing. We like what you're doing, but don't put it down in writing. So I went on for a couple more years, and in 1988, there was a big study that was done in the VA in Houston on CPR and hospital patients. And one of the results of that, they found out that all of us 65 or so patients over age 70, none of them survived the CPR and to be discharged. And I thought, we got to tell people this piece of information. And so the next thing I did was then I wrote a draft of a booklet and I handed it out to the ethics committee, and they all said, "Oh, this is great. Let's do this." So that was started out with just a little pamphlet. It's 34 pages, and it said hard choices for loving people, and the subtitle was CPR, artificial feeding tubes, and the nursing home residents, which is the world I knew at the time. And actually, it was a hospice in California that started buying them by the thousands. And I was a nursing home chaplain, and I was under the mistaken idea that everybody in hospice had already made all these decisions about the end of life, and they were all ready to die, and it was all going to be. Why were they buying this book on making end of life decisions? And so anyway, long story short, I've changed the subtitle over the years. I did then changed it to elderly patients. And then I realized the research was saying it's not just because you're old, you're dying because of medical problems, whether you're a child or a 50-year-old or an 80-year-old. So I changed it to patients with a terminal illness, and then I changed it to patients with a life-threatening illness. And this most recent edition, which came out in 2016, it's with patients with a serious illness. So I'll talk about that in just for a minute. So I'm going to share the screen here, and I do have slides. My plan is to talk for about a half hour or so, and then stop and take off the screen share, and then let you ask questions. And then if I get to the rest of my slides, that's great. If I don't, that's fine too. So I want this to be what you're hoping for. But first thing, a message from our sponsors. And that is, and Susan didn't ask me to do this. I says, can I do this? Because I wanted to show you on their website where it says for patients and families, you click on that and the drag down menu comes on, and it's take charge. And so this is done so well. We cover a lot of the same territory that I'm going to talk about today, although I'm more talking about specific healthcare decisions and how to make them. But this is just really good. So I encourage you, if you have not gone to the website and checked out these things, it's really helpful. Send your friends, your family to them too. It's really great. So anyway, thank you, Susan. Thank you, Mission Hospice, for doing that. So I got interested in advanced directives, living wills, and stuff like that. My wife knows that, and she was on a plane one time, and this man came down the aisle going to his seat, and he had this advanced directive on his shirt. It says, "If I'm ever on life support, unplug me, then plug me back in and see if that works." I was kind of a light way of looking at advanced directives. Here's actually another advanced directive, and this is true story. This man showed up in an emergency room in Miami, Florida, 70 years old. He had an elevated blood alcohol level, and he was unconscious. So they start treating him in the emergency room and pull his shirt off, and lo and behold, he has this "do not resuscitate" on his chest, tattooed on his chest, and this cloudy area down here was his signature, or assumed his signature. It turned out it was. And the hospital said, "Oh, can we recognize this? Is this a legal advanced directive?" And at first, the ethics committee met. The guy was still non-responsive. They hadn't found the family. And they said, "We don't know where this came from. You know, maybe guy was in a drunken stupor one night and said, I think I'll get do not resuscitate on my chest." So they eventually did decide we're going to honor this, and they were able, before the guy needed it got coded, he were able to find the family, and they verified, oh yeah, Dad, he did not want to be have any resuscitation attempts. So this is in general what we're talking about, and that is letting our wishes be made known of what we would like done at the end of life. I'm going to just give you a definition here of serious illness to start out with. Let me just say, as a disclaimer, I'm not giving medical advice to any of you who are listening to this, nor is Mission Hospice. I'm going to share a lot of medical information that's based on research, it's based on medical journals, and a lot of my own personal experience, family experience, professional experience, but there is nothing substituting for you to talk to your own physician, physician of those you're caring for. Uh, I, I, I cannot give advice about whatever particular situation you're in. And being a chaplain and not a doctor, even when I'm operating professionally, I always steer families and patients to their physician, to their nurse, to the people, the medical side of it, to make these medical decisions. So just that one caveat, and you keep that in mind as we go through this. So serious illness, this is an official definition. I think this is from World Health Organization, I believe is where this came from. So the reason I'm sharing this definition with you is because a lot of these things I'm going to talk about, all these things I'm going to talk about in the context of serious illness, like CPR does help some people some of the time. But those with serious illness, it helps very little bit of the time. So that's why I'm making the distinction here. I just want you to know who we're talking about when we say patients have a serious illness. So there's a high risk of mortality, though cure may remain a possibility. Another actual definition I found, they said if you have a less than 25% chance of survival, we consider that a serious illness. The patient has a strong negative, the illness has a strong negative impact on one's quality of life and functioning in life's roles, independent of its impact on mortality. And then there's the impact on the caregivers, and or it is burdensome in symptoms, treatments, or caregiver stress. This could include time and activities dominated by the illness's treatment, and or the physical, emotional, and financial stress on caregiver and the family. So that's just a place we're gonna start. That is all these things I'm going to talk about today is really related to serious illness. So let me kind of tell you about a story of this woman. She was a volunteer at the nursing home where I worked, and I got this picture out of a nursing home newsletter, and she had found some abandoned birds in her yard, and she was working trying to raise them, and so she brought them into the nursing home one day. That's what the picture's about. But she came to me on a Monday morning. I've been have been doing this for about 10 years and talking to lots of folks about making end of life decisions. And she came to me on a Monday morning. She says, Hank, I've got to make a life and death decision about my mother by Thursday. And she starts to cry as she's telling me this. And I says, well, let's sit down and talk. So we found a place to get some privacy. And I said, well, tell me what's going on. And she says, well, Mom's down in the hospital in Virginia Beach, which is about a 3-hour drive from where we were in Northern Virginia. And she's on dialysis. And my brothers and sisters and I have to decide whether to take her off dialysis and let her die. And I said, well, tell me more about it. Has she been sick for a while or just all of a sudden gone into kidney failure? Said, oh, gosh, she's been sick for a long time. She's had 2 strokes in the last 2 years. And, of course, now her kidneys are failing. And then I said, what do the docs say? Is the treatment doing any good? And they said, oh, they don't think it's doing any good at all. And then I said, did your mother ever give any indication what she would have wanted done in a situation like this? And she said, oh, yeah. Mom said she never wanted to be on dialysis. And I'm thinking, what's wrong with this picture here? And I said, Jerry, this is not a hard decision. I says, of course you take your mom off dialysis for all the reasons you just gave me. It's at the end of a long decline in her health. It's the docs say it's not doing it again. Mom said that she didn't want to be on a dialysis. And then I said to her, what's going on here if that makes this so difficult? And she started to cry again. And she says, I think I'm feeling guilty because I haven't visited mom enough. Well, she said guilt. I know she was moving into my area. You know, I'm a Baptist. Now we Baptists think we have more guilt than the rest of you guys, but there's a famous Catholic guilt and Jewish guilt, and I've even run into atheist guilt out there. So there's enough guilt to go around. But so what she was dealing with was an emotional, spiritual issue. Had nothing to do with the dialysis that we're treating her mom with. So I have come up with these theorems, I call them, and they're in your handouts. The very last page of the handouts has all of these gathered together. So if you don't have it in front of you, that's fine. But maybe later, if you want to get them, you can see them, because I'm going to run through a bunch of them in the next hour or so. But this theorem goes like this. For patients and families, end-of-life decisions have little to do with medicine, law, ethics, religion, or morality. For them, the decisions are almost wholly emotional and spiritual in their nature. Yeah, they have something to do with medicine. They have, is it legal? Can you take somebody off dialysis once it's started? I mean, there's a lot of questions like that. And when I say religion here as opposed to spiritual down here, I mean, your particular religious group, and the most famous of those would be like the Jehovah's Witness and blood transfusions. They don't receive blood. It's just, they don't do it. And it's a religious conviction of theirs. Spiritual, I mean, is the things all of us have to, what's been the meaning of my life? Do I need forgiveness? What's going to happen to me after I die? Those types of questions, most everybody asks, whether you're religious or not. So what was happening with my friend, she was feeling guilty, but the treatment decision was based on her guilt, not on what her mom wanted. So I've kind of concluded, and this is now 35 years doing this work, this is what patients or families are mostly dealing with when they have to face these decisions, these end-of-life decisions. So what I'm going to look at today, these are the four most common of the treatment decisions. What about CPR, artificial hydration, nutrition? I'll talk also about IVs for hydration in dying patients. What about hospitalization of, let's say, a nursing home resident or assisted living resident? Do we send them to the hospital? And finally, when do you move to palliative care or comfort measures only or hospice approach at the end of life? My plan is I'm going to talk a little bit about goals of care, and then talk about CPR. Then I'm going to stop talking about the treatments, and I'm going to go ahead and talk about some questions you can ask to help make these end-of-life decisions. And then I'll just talk, I have 2 slides on how COVID has made these decisions different, but how they're the same. So at that point, I'm going to stop, and then we'll take questions and discussion. And if we have time, we'll do the rest of this. It's in your handouts. If I don't get to it, it's going to be fine. You can, of course, get my book and you can find out about it too. So that's the plan. That's where I'm heading with all this. So let's talk about goals of care. I had this patient. He was 14 years old, hospice patient. He was very close to dying. He had tumors all over his chest. You can see when he had a t-shirt on, you can see bumps all over his chest. He was just riddled with cancer. And his parents were divorced. He lived with his mom, and his mom was really religious, and she was expecting God to do a miracle, and she wanted everything done to keep her son alive. And so she was prepared, if he stopped breathing, she was going to call the rescue squad and get him put on a ventilator and do whatever they could to try to keep him alive. So the nurse, the social worker said, Hank, can you help? And I said, well, I'll see what I can do. So I got in there and talked to the mother of the patients in the room away from us. So we're talking in her living room, and so we got talking about it, and I really, knowing the research, I know it says, CPR just doesn't work for patients like your son. It'd be dragging him through some really difficult times. And I was trying to talk her out of it, and she said, "Well, I just want to give God a chance to do everything He can." And so I was getting nowhere, and all of a sudden, just in the back of my mind, I started listening to the lectures. I'm going around the country telling people, always talk about goals first. Don't talk about treatment until you talk about goals. So I decided to change my tack with this lady. And I said, and I thought to myself, she has got to know her son's dying. And so I said to her, "What's the most peaceful death you can imagine for your son?" And she says, "I've thought a lot about that. And I'm hoping that one day I just come into his bedroom and he's died in his sleep at night." And I said, "You know what? We can help you with that." And that's what hospice is all about, to keep him comfortable uh, in his own bed and die peacefully. And I told her, and I turned it into one of my theorems, it says, dying peacefully at home takes a lot of planning and preparation. And so what I'm talking about today, what they're talking about on the Take Charge thing on the website, is about preparing for a peaceful death. And it takes planning. It doesn't just happen by accident. Usually the accident is dying in the hospital, hooked up to machines. So where do we start? Goals of care. Um, I have these 3 goals. It's a short list. I like it. I borrowed it from a nurse professor at Georgetown a couple of years ago, and I asked her if I could borrow it. She said, "Use the list." So that's okay. I stole it from somebody else anyway. So anyway, so 3 goals of care perhaps, and that is cure. You get an infection, you take an antibiotic, you get over the infection, you're cured. A lot of medicine has traveled, practiced to take care of diseases like that. Maybe we can't cure something, but we can stabilize somebody's functioning. So diabetes would be a good example of this. We have no cure for diabetes, but with proper diet and medication, people can live for a very long time with very good quality of life and never be cured, but stabilize the functioning. And maybe if we can't accomplish those 2, then it's time to prepare for a comfortable and dignified death. And this is the time we switch to comfort care only measures, or hospice approach, preparing for a comfortable and dignified death. Now you can mix and match these things, because I know I've had many hospice patients who stop chemotherapy for cancer, but they get pneumonia and they decide they want to try to treat the pneumonia. And you can do that. You can kind of do a mix and match. And you don't have to go through all these to get to here. You can sometimes, again, the cancer patient who says, "I'm not going to do any more chemo. I'm not going to fight it anymore. I want to prepare for a comfortable and dignified death." So not even trying to stabilize. We're just going to get ready for the end. So this is selling goals. This is kind of the new buzzword in medical journals nowadays, is calling goal concordant care. So the doc is trying to help the patient, the family, come up with a care plan, which the doc will suggest, but in uh, concordance with the goals, the values that the patient has. So that's what the whole idea of doing goal concordant care. So let's talk about CPR. I've got a confession. Um, During the pandemic, my 21-year-old daughter has got us binge watching Grey's Anatomy. We started back in March, and we've gone through 11 seasons of Grey's Anatomy. So it's, I don't know, well over 250, 300 episodes of this show. I tell this because Grey's Anatomy and House were part of a study of how well CPR was done in these um, 2 shows. And by the way, and from personal experience, I can tell you, almost every episode of Grey's Anatomy, somebody's getting CPR, and almost all the time it works. So research has told us that um, for out of hospital CPR, survival rates are between 2 and 30%. Those are the studies. And then in hospital from anywhere 6.5 to 15%. These two shows the survival rate's about 72%. And they rarely talk about advanced directives and planning for CPR. So a lot of people get their information about CPR from TV shows. There was another study done about 2000 that had looked at the TV shows ER and Rescue 911. And same thing, the Rescue 911, which was a reality show. I mean, they actually following rescue squads. They were 100% successful in resuscitating people. The truth is, we don't know exactly who's going to survive, but we know 3 categories of patients who we know before we start CPR that it won't work. And this was a 1995 study, and I'm going to give you another study that updates it from January of this year. But anyway, first of all, the multi-diagnosed patient has more than 1 or 2 medical problems. And as we've listened to all this research on COVID, a lot of patients have underlying medical conditions. So those are the multiply diagnosed. They have COVID, they have pneumonia, they have congestive heart failure, whatever it is, diabetes, a lot of things. So what the medical community calls comorbidities. The next type of patient who doesn't survive, which would be all people who don't live independently, assisted living patients, memory care patients, nursing home patients, they don't survive. And lastly, would be the patients who have a terminal disease. So the terminal phase of cancer, heart failure, kidney failure. And the reason CPR doesn't help these people is because they're dying of their kidneys failing, and to beat on their chest doesn't really get the kidneys going again. So this is just basically what we know about the research. Oh, I told you there's a new study. This is in January of this year in JAGS, Journal of the American Geriatrics Association. This study was actually looking at survival rates of adults over 80, but they're asking doctors, was CPR appropriate or not appropriate for this person, which I'm not going to talk about that. What I did pick out all the statistics here on these frail old folks. Poor outcome of CPR for out of hospital cardiac arrest in persons 80 years or older had an overall survival rate to discharge of 2.1%. For patients with an unwitnessed, non-shockable cardiac arrest, survival to discharge was 0%. This non-shockable, you see on TV the paddles that they get to put to people's chest and put an electric shock to try to get their heart back into a normal rhythm. And by the way, that's only about 10% of heart attacks are shockable. So most of them are non-shockable. And then lastly, the survival to discharge for nursing home patients was 0 out of 107 that they tried to resuscitate. So CPR it doesn't work. So why do we do it? Well, it just becomes a symbolic gesture. I've been with families in the emergency room after somebody was transferred to the emergency room with CPR started in the nursing home, and they congratulate one another. We never stopped fighting. Dad was just a fighter, and I'm not trying to make judgment on their opinion of what should be tried, but for them it became a symbolic gesture. So let me just conclude this thing on CPR, and then we will move on to talking about questions to help. If the patient and the family are requesting CPR when there's no reasonable medical benefit, then find out the core issues and address them. I'm addressing these slides to medical professionals. So, someone says, I'm afraid of dying. Well, that's a legitimate concern. What is it? And maybe I'm afraid of going to hell. Well, I'll tell you, CPR is not going to keep you out of hell. You need clergy in there. You need their pastor, their rabbi, whoever it is that can help them with these spiritual issues. So rather just leave someone, again, for the medical professional who asks somebody, do you want to get CPR? And they say yes. We really need to find out what's behind that if we can address those issues. Another thing, a lot of times people hear when they say do not resuscitate, they hear do not care. And it doesn't mean that. It just means there's one treatment we're not going to do. We're not going to beat on your chest. We're not going to shock you. We're not going to stick in medications to try to get your heart going again. We'll let you die in peace. But people with a do not resuscitate order can go on a ventilator. They can be hospitalized. They can go in the ICU. They can go on dialysis. There's all kinds of other treatment that can happen, but it doesn't mean do not care. And so I always like to assure families when they say, especially families, but patients too, say, no, I don't want CPR, but are they just going to let me die and do nothing? And I say, oh, no. We do lots for dying patients. We keep you clean and dry, and if you're having a hard time breathing, clear your airway and give you oxygen. So it's what I call aggressive comfort therapy, really trying to keep people comfortable at the very end. Let me give you a rule of thumb. Now, don't tell the doctor I told you this. Again, this is just between you and me. Rule of thumb. If the physician is asking the patient or family to decide about withholding or withdrawing treatment, then it probably offers little, if any, medical benefit. Now, this is not a bad thing. I'm a relatively healthy person, and if I were to get pneumonia now, and my doc says, oh, I need to give you an antibiotic, here's a prescription, go get it filled, I'm going to do it. And the doc doesn't go into, there's too many antibiotics out there, and you can refuse this if you want. You might die, but you don't have to take this. We don't get into that discussion for a person who's basically healthy and are going to benefit from it. But down the road, if I've had dementia for 5 years and been in a nursing home for 4 years and I'm close to the end of my life, the doc might raise with my family, do you want to really do this again? Put him through that again, going to the hospital. So again, if the doc is asking about making a medical treatment decision, then it probably offers little, if any, medical benefit. So here's where I promise we get to questions to help making these end-of-life decisions. And this you can find in your handouts. I've got these, as of course, in my book, but on the handout. So the first question, we've already talked about it. I won't spend time on it, but what is the agreed upon goal of medical care for the patient at this phase of life? So what is goal concordant care? The second question is, what does the patient think about their current and probable future condition? My mother had been in assisted living, and we moved her to Colorado to be close to my sister, and she went into a memory care unit. And her health kept going down, and she got under hospice care. And she fell and broke her hip. We didn't send her to the emergency room. They sent her in a portable x-ray. Turns out she did. She had a broken hip. And we knew, I knew that the end was near. And so I flew out to Colorado, and my sister and I sat down with the hospice doc, and he had one question for us. And he said, how did your mother feel about her dementia? He didn't ask whether we should send her to the hospital or not. He didn't raise the question of surgery to repair the broken hip. How did your mother feel about her dementia? Now, of course, here I'm a son getting ready to lose his mother, but as I'm also a person who writes about this stuff, and I'm thinking, what a great question. And so we told him, Mom hated it when she was starting to lose her mind. She threatened suicide a couple times, and of course the sent the staff of the assisted living into a tizzy, and so we had to have sitters for until we got the psych consult in there. So anyway, the question is, how does the patient, what do they think about their current and probable future condition? Now this gets into the family making these decisions. So I have a couple theorems about this. Families who withdraw treatment from patients without decisional capacity always say something like, I know this decision is what my mother would have made for herself. And conversely, families who consider withdrawing treatment that would allow a natural death but decide to continue often, not always, but often say something like, I don't think I can live with myself if I ordered the withdrawal. So I think it's, and for all of you who are here trying to figure out what to say to your family, it really helps families to know that this is a decision you would have, this is what you would want. And they can tell the doctor, and the doctors like to hear that too. They say, oh, we know Mom would not want this treatment. We're going to stop it. Here's an interesting one. The ability to let go increases as the emotional and geographical distance between the family member and the patient decreases. As hard as it is to make these decisions, it's easier for a spouse to make it for their husband or wife than a child or a cousin or a court-appointed attorney. So the emotional distance, the farther you get, the it gets more difficult. But also the geographical distance, the one who's living in the same town as a family member tends to make this decision easier than the other. Now, this is from a number of years ago. Decision making the incompetent, the daughter from California syndrome. I'm sorry. I know you know in California we talk about you guys all the time, but this is in another one, article in JAGS, but they did say in this footnote here, editor's note, in California, we refer to the same condition as the daughter from Ontario syndrome, or occasionally as the daughter from New York syndrome. So what it is, so the daughter locally, she's been caring for Mom, had Mom live in her home for years with dementia, now in the nursing home. And the daughter from New York flies in every once in a while and says, oh, I love Mom so much. Let's do everything we can to keep her alive. And of course, the daughter locally, she said, where have you been this whole time that I've been taking care of Mom? I was doing a webinar 2 years ago with a group, and the host, we were on the meeting for a time before the webinar started, and he was a doc down in Texas, and he said, oh, I liked your slide about the dollar in California syndrome. He says, in Texas, we call them seagulls. I said, seagulls. He says, yeah, they fly in from the coast, they make a lot of noise, they crap all over everything, and then they leave. So it is, and like I said, this is something I picked up in the medical literature we're talking about. So for those of you who are trying to explain things to your siblings that are far away, this is a common difficulty that you might have to run into. And I'm telling you about the families because we're trying to establish what does the patient think about their current or probable future medical condition. This question, of course, the next one is what's in the best interest of the patient. So in medical ethics speak, we're trying to do beneficence, what will benefit the patients, and avoid harming the patients, non-maleficence. So we're trying to establish what is in the best interest of the patient. And this is a very subjective question. I can't tell you this is in your best interest, or you have to decide for yourself or for your family member. This is a question for the medical professionals. What are the prognosis and probable consequences if a certain treatment plan is followed. Let me give you, and this is, you can, if you're taking notes here, you can Google best case, worst case whiteboard, and you'll find several. This is mainly for physicians, helping physicians how to talk to patients and families. And so they talk about two different treatment options. What's the best case for this one? What's the worst case? What's the most likely case? So even if your physician that you're talking with doesn't have the whiteboard to talk about this with you, ask him or her, you know, if we, as we're just trying to decide this treatment plan, what is the best case? What's the worst case? What's most likely to happen? And so that's where this can really help, is for the physicians to be able to tell you what's best case, worst case, and what's most likely. Always include supportive care only or comfort care only as one possible treatment choice. So if the physician is laying out, you know, ventilator support in the ICU, just ask, well, what can you do for mom if we just keep her comfortable where she is? And hopefully the physician will be able to say, oh, there's a lot we can do to keep her comfortable and not put her on the ventilator, or whatever the treatment decision might be. So the last question is, if these treatments point to withholding or withdrawing, or the answers to these questions point to withholding or withdrawing life-prolonging treatment, then the big question is, can I let go and let things be? And that's, of course, where you get into the emotional, spiritual issues of being able to let go at the end of life. Let me give you one more theorem right here. And this I've somewhere, I think I thought this up, but maybe I heard it somewhere. You can never make a wrong decision. You just do the best you can with the information you have at the time. And I have people understandably struggle with decisions, whether to put mom in the hospital or not, whether to do CPR or not. And people, I don't want to make a mistake. Well, you just do the best you can with the information you have at the time. And you will not make a wrong decision. You might look back on it and say, I wish we hadn't done that. But you have information now that you didn't have back then. So let me say a couple things about COVID. What has not changed with end-of-life planning with COVID, the process of coming to a treatment plan is exactly the same. And I just went through this. Establish goal, discerning the patient health values, seeking the best interest of the patient, gather information from the medical professionals about prognosis and consequences, and finally, processing the emotional and spiritual concerns at the end of life. What has changed, and I am not working day to day in the healthcare field right now, so I've gathered, I'll read everything I can on this in the medical literature, as well as the newspapers and what I pick up, you know, watching the news and things like that. So this is kind of my discernment and talking. I do talk to physicians who are caring for people with COVID. One thing is the patient's condition can deteriorate quite rapidly. You might not have a lot of time to talk about what you want or don't want. The family might be prohibited from visiting the patient, and this can impact decisions you make, because if you can't get in there to see what mom looks like when she's hooked up to all these machines and just see it through somebody holding up an iPad, it might not be, you get an idea, but there's nothing like sitting there, holding their hand, seeing them struggle or not struggle, seeing them at peace or not at peace. And so, so if you're not allowed to be in there, it could impact these decisions. Research on prognosis and treatment continues to evolve. I've changed my instruction to my wife a couple times during COVID, as the latest research comes in. You know what I told you? I don't want that anymore. I'm going to change my mind. So resources could be on short supply. Early on, of course, we heard a lot about shortage of ventilators. I think right now that's not a problem, but if a hospital is forced to triage patients who could get a ventilator or not get a ventilator, it might impact on the decision making. Again, fortunately, from what I read, this is not a problem, and really hasn't been a problem for most everybody. And lastly, because the quarantine is present at the time of death and during the grief rituals may have changed. And this can be good and bad. I was listening to a podcast and some docs talking about this very thing, and they talked about this patient who was dying, and because they were a hospice, the family could get in, but they also brought in a Zoom meeting, and there was relatives in Japan. They were able to be with them at the time of death. So, but we're going to get through this, and grief is going to be different. But if you can be with your loved one when they die, maybe even wash them, whatever rituals you might have and your family for dealing with stuff like this. So I'm going to stop the share here for a second, and we're going to open it up for questions. And Susan, you're going to host this, but I'll listen carefully to what you have to say.
Thank you. Yes, I am going to just want to let people know that if you have a question, one way to share the question would be in the chat. And if those of you that have not been on Zoom for long enough to use chat, you can move your cursor to the bottom of the page or the top of the page, depending on how you're joining us. There will be a set of icons, and one will say chat. The other way is to go to the participant icon at the bottom or top of your screen. Click on that, and there will be an opportunity there to raise your hand, which is actually the most effective way, because then I'll just get a list of people with their hands up, and I'll be able to call on you in the order that you have asked your question. So there are some people in the room that I see that are on their cell phones, and that is a function. I'm just not sure how that all works out in Zoom on the cell phone. So there's actually just one or two people on cell phones. If you are interested in sharing or asking a question, would you just please unmute yourself right now? And I'm going to make that, I'm going to give you the opportunity to unmute yourself. So if you are unmuting yourself, I'll see that. And if you are not interested in asking a question, then I will just go ahead and see. Is anybody, so thank you. Mukund, who is not a plant here, he's actually one of our community education. He is one of the supervisors, he's not a supervisor, but he is instrumental in the training that we do for our community education folks on advanced care planning. And so Mukund, could you just go ahead and unmute yourself? And
thank you, Susan. And I just want to start by saying that Susan's called me worse things than a potted plant. I'm kidding, Susan, you know that. Chaplain Dunn, I want to start by saying that I watched several presentations on this topic. And I find yours exceptional in the sense, in the way in which the choices, having to make those medical trades and decisions were portrayed. I think that it was extremely well done, and I learned a lot about how to do that from listening to you. The CPR discussion, for example, is something that I hear a lot, but the way you broke it down and provided, I guess, a logical process for determining your loved one's viability of getting through CPR successfully, I think that was very well done. So thank you for that, and I really enjoyed your talk. I'm sure I'll go back and listen to this again and learn some more. The question I had for you is, I love Hank's theorems. They're very, very good. But the question I have for you is, every theorem has a corollary to it. So have you thought about how you might use that in terms of thinking about sort of what an opposite to or other circumstances to the theorem that you have? Is that a useful construct for us, even as users of your talk, in terms of helping us make our own decisions on values, how we might use that construct?
Okay, let me just make sure I understand what you're asking. So how to best clarify your values as you approach these end-of-life
Well,
decisions?
yeah, so yes, so the idea of the main reason we would want to, main thing hopefully we would take away from your talk is to get a better understanding of how we would construct our own values.
Right. Yeah.
And your theorems are a good, really source of thinking about things explicitly. But a corollary to that theorem, looking at the mirror image, the opposite point of view, is that a helpful construct also for us to work with?
Oh, interesting. Oh, so again, I'm trying to get exactly what you're asking. So what I'm going to answer it then is how do you sort through your own values, and you use the word opposite. So if there's a choice of ways of going through the treatments, is that right? Okay.
Right.
Well, setting your values, let's say you have a life-threatening illness and the physician's talking to you, and they might ask questions like, what's most important to you? Length of life or quality of life? We can keep you alive a lot longer, but you're going to be pretty disabled, and probably your dementia is going to get worse and worse. Or we can keep you comfortable. We don't live as long, but we're going to just emphasize your comfort. So it's really getting at, and then the physicians really want to know this. What are your values? And so I think what you're getting at is just is we can think of both sides of. That's why when I suggested the doctors using that best case, worst case, most likely case, and to do a couple treatment options. We can try ventilator support or just comfort support, supportive care. So it's hopefully you can think through several options, and the physicians will, and nurses and other medical professionals can help you do that. That's again, I go to the take charge. You because you're familiar with Mission Hospice, you can go to the take charge. They have a lot of questions that help you sort through these things too. There's a couple other, Susan, I'll give you some other resources people can link online of the Conversation Project and other. They have little things you can go through to help you sort through your own values of these things.
Good, thank you.
Yes.
Yes.
Mary Jo Power, could you unmute yourself, please?
There you go.
Thank you.
Yeah, I've worked with people who I've worked in a hospital, and I really love the goals directed, how you've termed that, because people will come in and they'll talk about, well, I just want to be on the tube for 4 days. You know, put like real firm parameters on what they think they want, or I want to be resuscitated, but if only, again, 4 days, 5 days, or I want to be kept alive to have my wedding. You know, various goals that people think that they have when they don't really know what they're talking about. Meaning they haven't really discussed what goals mean. And to me, goals mean, how do you want to live your life? What is your quality of life? And when when it comes to the discussion with the doctor, whether or not the patient can make their own decisions, what is really helpful is if the family knows what the patient has said, how they want to live. Oh, my mother, my dear mother wouldn't want to live in a nursing facility. They wouldn't want anybody taking care of her. She's very independent. Those, I think, are the most important things that you can get from a person. And it's so important, as you said on your, when you first started, is families and people just need to have these conversations before anything happens. Because it's so much not like Grey's Anatomy when you come into the hospital. And it's really difficult for people to understand that it's really not like the TV show.
Right.
Things happen so quickly. So I really love the part when you said about the goals, because
Okay.
a goal isn't to be on a tube for 3 days. That's not your goal. A goal is, how do you want to live the rest of your life?
Yeah. Yeah, I really encourage people, if you're doing living wills, piece of paper, make them as general as possible. You know, if I'm dying, I don't want anything artificial keep me going. And then assign a healthcare proxy. There are some docs of quite renown who do not like living wills at all because they have to be interpreted. And they say the healthcare proxy, you've got to talk to your family and they can make these decisions when you can't make decisions for yourself. So, and update the information to the family members. There just 2 weeks ago, I listened to this podcast called Jerry Powell Podcast, and they interviewed a doc named Sean Morrison, who has a new article out in, I want to say JAGS, I think. But anyway, a new article, and he says, advanced directives, advanced care planning, simple, clear, and wrong. And I thought, wrong? What do you mean? I've been talking about this for years. Well, one of his things is people do a living will, you know, let's say at age 60, and they end up in the hospital in the ICU at age 80, and they've never revisited it. And so, you know, here's a 60-year-old trying to guess what he's going to feel like at 80 years old, and you don't really know. I can't tell you the number of times at the nursing home we'd have somebody in there. It was usually a man who the wife would tell me, says, you know, Bill had always said, if I have to be in a nursing home, I want you to take me out and shoot me. And then he ends up with a stroke. He doesn't like it, but he has adjusted. He continues to eat. He goes to, you know, religious programs. He goes to bingo. He would never have chosen this life, but he's just, the human spirit's amazingly adaptable. And yes, there is a lot of depression in nursing homes because of the situation they're in, and we need to address that too. But you know, you just don't know how you're going to respond. So, thank you. I can get back into it, or if you got any other questions, well, we're going to stop in a half hour, right, Susan?
Yes, thanks, Hank. I think if we, I see somebody's just unmuted themselves. I don't know, Stephanie, if you had a quick question.
Yeah.
Is it okay?
Yep, go ahead.
Hi there. Great being with all of you, and thank you for your guidance and validation and what you're, you know, what Mission Hospice and what you're sharing in terms of how to have these conversations, which is what I do with a lot of people. I love the fact that you shared about your experience with the doctor and the question about dementia. It was like another aha about, like, how does your mom feel about, so that was like a beautiful, that we can always be on the other end. How are we on the other end? Because it's always different when your personal experience. I know it's probably in here, but sometimes when I'm walking through, not so much with this individual's serious illness, which I know this is what we're covering, but the idea of, you know, what's quality of life, what is a value, and like really getting that into those like 2 or 3 really quick to add with advanced care directives. And I'm curious what your thoughts are, like really getting there very quick when you have a window to talk about that it expands and gets a little more clarity around the person's being when you have an opportunity for advanced care. Like, I know it's about advanced care planning and there's so many tools, but are there a couple nuggets that you come to instead of just saying quality of life, or what's that question to really get to the essence of the person, to get them talking, or, you know, to get those little nuggets? Do you?
Yeah, yeah. Well, I've kind of said some of them, but
Yeah.
you know, what's important to you, and um, and can make suggestions. Just, I mean, it's a cliche, but I had this aunt who had advanced cancers, and she used the word. She says, "I want to go for quality, not quantity." So that's a good way if that's the choice that people are having to make, quality versus quantity. You know, again, the physicians can help people and nurses can help people knowing what the choices are. We can keep you alive longer, but you're going to experience a lot more mental deficits. What's more important to you? And some people may say, well, I want to live as long as possible. Or their family members may say that they want them kept alive as long as possible. But let's ask that question. So the main thing is of talking values. What do you value most at this place in your life?
Yeah.
And that's why the you know, they call it goal concordant care. We want to set the goals, which the medical team can help them with that, but it's got to be the patient, the family, identifying those.
Yeah. I just feel it's also interesting because I'm still hearing about like our change in language about like pulling the plug or just take me out and shoot me. Like, and I'm like, well, that's not very helpful for these conversations. Like, you know,
Well,
having to like reframe it for people, because I'm like, okay, that's great. But how do
yeah.
you help your daughter, who's my best friend, walk you through this? Because that's not an option for her. So, like, I kind of challenge people a little bit more on that, which is because I'm like, that's not very helpful.
Right.
So I don't know if you're still come across that a lot, because it
Right.
change.
But that kind of statement can help you when you have to decide whether you're going to hospitalize that person or not. Well, this is how they felt about being in a nursing home. And so let's just keep them comfortable and not try to prolong their life. You know, I mean, we don't go out and shoot people, fortunately, but people express that, and that's a statement of value. Again, the point that I was making when I mentioned that is that you say that when you're healthy out there working in your yard, and you have a stroke and in a wheelchair, and you know, I'd rather not be here, but I'm here, so let's make the best of it. Again, the human spirit is amazing. There's been a lot of research on this, quality of life, looking at quality of life, and the question with, let's say, frail elderly patients and their younger physicians, and they ask, you know, how do you evaluate the quality of life of this patient? And they ask the patient the same question: how will you evaluate your quality of life? And invariably, the patient evaluates their quality of life as better than what the younger physician, says about their life. And I saw this in my own parents, my other relatives, and then the years I've been, especially my years in the nursing home. Everybody would say, I don't want to be in a nursing home, but they end up there and they just try to make the best of it. And some of them can actually thrive in that environment. So good luck on that. All right.
I think, Hank, if you could go, maybe we could do another
Okay, we'll go. I'll
15
go.
minutes, and then Q&A.
Yeah, we'll just stop wherever I get to and go from there. So no problem.
Thank you. And I'll just sort of wave when it's about 15 minutes, so you don't have to worry about that.
Okay. So you stay up on my screen. I'm not sure about all this stuff here. Okay, hydration and nutrition, artificial hydration and nutrition. So this would be feeding tubes. And I'll start with just saying a couple things, what I call an important starting point, talking about artificial hydration and nutrition. You might hear me say some things you think I'm against feeding tubes. I'm not. I've seen them used in wonderful ways. Patients with throat cancer, sometimes they can't swallow anymore, but get a feeding tube and live in their own home and just feed themselves with their, pour a can of Ensure a couple times a day or several times a day into. Secondly, IV fluids or feeding tubes do not quench thirst. A lot of people will know somebody's dying and they might say, you know, shouldn't we start an IV to keep mom comfortable? Well, the research is pumping fluids into someone as they're dying doesn't quench thirst. Ice chips, sponge swabs in the mouth, there's a lot we can do to alleviate the sense of thirst without starting a feeding tube. It does not address it. Stopping eating at the end of life is very normal, but always explore other reasons why the patient has stopped eating besides being at the end of life. Are they depressed? Has there been a change of medication? So if they've been eating okay and all of a sudden stop, you really need to look at other reasons why they might have stopped. If their eating has been going down, 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 and they stopped, yeah, that very well could be. I know when my father was dying, he had been in a nursing home 4.5 years, and mom called me on a Sunday night and said, your dad can't eat anymore. And she, of course, was just torn up about that, but got off the phone and booked a flight to Florida. I knew dad was dying. And so he died 6 days later. So stopping eating is a sign that the end of life is near, but not necessarily. And lastly, on feeding tubes, the choice is not necessarily between artificial feeding and no feeding, but between artificial feeding and careful hand feeding. These patients, it can be very difficult to feed some of these patients, but it can be done with trained people, and it can usually train family members how to feed some of these difficult to feed patients. So here's some of the benefits of withholding artificial hydration in the dying patient. Again, this is the seriously ill dying patient that we're talking about here. You have less fluid in the lungs, there's less congestion, less fluid in the throat, less need for suctioning. For patients who have tumors, there's less pain. Of course, you have less fluid going in, you know, like less coming out, less risk of bed sores. Less fluid retained in the body, in the patient's hands, feet, and the whole body in general. Patient's more comfortable. And this last one is most fascinating to me. As the body naturally dehydrates, chemicals are released. They're like an endorphin that is released in the body. It's like we were created to go out of this world as gently as possible, and the way we've done it since the beginning of time is to stop eating and drinking at the end of life, and we can go out more peacefully. It's a very peaceful death. And for myself and my mother, my father, the choice was no IVs, no feeding tubes, just let them go peacefully. And that's how I want to go. Let me talk for just a moment about Alzheimer's. I'll show this just real quickly. This is my family of origin. This is 1960. This is me at 12 years old. All the older people, except for this woman right here, had some sort of dementia. My mother, probably Alzheimer's. Dad, multi-infarct dementia. Uncle Bob, probably Alzheimer's. Aunt Marion, probably Alzheimer's. Uncle Dennis, probably Alzheimer's. And my grandmother, she died in the 70s, and they didn't call it Alzheimer's. It was hardening of the arteries. So this is the story of all of us. There's a lot more to mention, a lot that we're going to have to deal with. One of the things, there's eating difficulties with advanced dementia, and there's actually some good news about this. At one time, about 30% of the patients in the country were getting feeding tubes for advanced dementia. but it's been going down over the years, and there's only about 6% that get feeding tubes now. This is in your handouts, and it's just some recommendations about doctors don't put feeding tubes in. This is also in your handouts, and there's a lot of updated research on this. But basically, for dementia patients, there's really no benefit for a dementia patient having, advanced dementia patient having a feeding tube. One of the things they'll tell you is that, oh, we're afraid they're going to get aspiration pneumonia. But you can get aspiration pneumonia with a feeding tube. So they don't live longer. You put a feeding tube in an advanced dementia, but they die about the same amount of time. They don't improve pressure sore outcomes. That's one of the reasons a lot of times they say you need a feeding tube to keep their nutrition up to keep them from getting bed sores. There's no evidence that it improves that situation. There's a lot of infections that go along with feeding tubes, and dementia patients are not made more comfortable with feeding tubes, but they are actually made less comfortable. So why do we do a treatment that we know doesn't offer any benefit at all? And I'd like to show a couple slides about that. You know, when we love someone and care for them, we feed them, whether it's a little baby. This little child came in to visit this old man, and they, you know, when people are young, we feed them, or you know, when they're older. Oops, went the wrong way here. Sorry about that. This lady couldn't wait for the nurse to come in and feed this other lady at the table at the nursing home. She's trying to help her feed. So we love them, we care for them, we feed them. And this is a careful hand feeding of a patient that has eating difficulties. In my mind, there's a great deal of difference between careful hand feeding and artificial feeding tube. Now, some people don't make that distinction, and it's kind of what you value. And some people say, and I've had families say this, I could never not feed mother and with a feeding tube. I mean, they were being fed with a feeding tube, and they said, I could never not feed mother. It had the same emotional and spiritual value of for them to be fed with a feeding tube. Let me introduce one idea to you. It's called VSED, voluntarily stopping eating and drinking. A patient may choose stop eating and drinking to hasten death. This is based on the well-established principle of autonomy, allowing a patient to refuse treatment. VSED becomes problematic, though, when you're trying to decide about it, advanced dementia patients and patients and how to put this in a living will. There's some great videos out there. You could probably search on YouTube about patients who have decided to stop eating. These are competent patients who make their own decisions. And this one YouTube video I watched was this woman, and she had a big smile on her face. She says, I decided, she fell, she broke her back. She was in misery, she was in pain, she had been independent. She says, I'm gonna fast until I die. And so her daughter videoed this, and every day through the fast before she died, she didn't have the last couple days up to the time of death, but this was her choice to allow her to die more quickly. The problem with dementia patients, and let's say you put it in the living will, say, look, if I get advanced dementia, and you can give all kind of reasons or criteria for stopping it. What if I still open my mouth after I said I don't want, if I get to this place in life, I don't want to be hand-fed anymore. This is just statistics on when people stop eating, half are dead in 8 days, 80% are dead in 14 days. Goes out from there. This lady, Margot Bentley, she had said, I don't want to be fed if I have dementia and I don't know my family, and all I am is bedbound. So the family asked to stop the feeding, but the facility went to court to get a court order to stop the feeding. And the lady continued to open her mouth and accept food. And the judge said, that's her, she's changed her mind. So now she's accepting food. So I'm just telling you this. It is something that you can decide ahead of time. Um, there are groups and organizations that are helping people write living wills that would want to say that about advanced dementia. It's a very individualized thing. And yeah, I have been involved with a number of cases where families with dementia patients said, Mom would not like to be kept alive like this, and they withheld hand feeding to let them die peacefully. So in summary, on artificial hydration nutrition, you can consider a time limit to trial. That is, try a feeding tube for a short period of time. If it helps and seems to get the person over a bad time, then it might be appropriate. And by the way, you can try this with all kinds of treatment. Dialysis, try it for a little while. Ventilator support, hospitalization, antibiotics. Time limited trials is a good way. Let's say you don't know what the patient exactly would want, so you might can try it for a short period of time. I've already talked about dying without artificial hydration. Promotes a peaceful death. Same thing with dementia. Don't do it. It does not help the patient. It makes it worse. According to ethics and the law, if a treatment can be refused in the first place, it can be withdrawn. And when withdrawing treatment is not killing the patient is dying from the pathology that rendered them incapable of eating. I had this patient one time. She was 36 years old. Her mother and her sister were the caregivers. She was in the nursing home. And she had had a brain tumor, and I had gone to, they did an operation on her brain. They had a bleed on the operating table. She was without blood to her brain for a period of time. They were able to stop the bleed and kept her going, but she ended up in a vegetative state. No response to her environment. So after like 2 years of this, the doctor suggested to the family and wrote in the medical record, it says, if this was my daughter, I would stop the feeding and let her go. And the family, the mother, one time my chaplain's office happened to be right across the hall from this patient. So I got to know this family very well. So the mother came into my office one day and she was just with tears. She said, if we stop the feeding, will I be killing my daughter? And I said, of course not. Your daughter is dying from a brain tumor, or at least the bleed on the operating table. You know, you have nothing to do with the fact that your daughter is dying. The timing maybe, but not the fact of. So it's something we can really help when people are withholding or withdrawing any of these treatments, to know that it is the disease that's killing the patient, not the withdrawing of the treatment. This was a man also at the nursing home. He was on dialysis. He'd go out to the dialysis center 3 times a week, and he just got tired of it. It wasn't doing him any good, and he felt terrible. So he started thinking about stopping the dialysis. He was a devout Catholic, and he asked if I could come see him one day, and I said, sure. And so he had a question for me. He says, if I stop the dialysis, will I be committing suicide? And I said, no, absolutely not. You'll be dying of kidney failure. That is the cause of your death. And he did. He stopped the dialysis and died very peacefully. Withholding or withdrawing treatment does not kill the patient. It allows a natural death to occur. I won't take the time to talk a lot about this, but this is how I started this craziness on these theorems. The peacefulness of death is directly proportional for the distance from the hospital ICU. And usually we think the most peaceful death is in our own bed or our own home. If that's not possible, then in the nursing home or assisted living. If that's not possible, then a general ward of a hospital. A lot of us say we really don't want to be in the ICU, and that's the least peaceful death. So I know I've been a part of many peaceful deaths in the ICU. It can happen, but usually that getting there, you get machines and all kinds of stuff before the patient or the family decides to withhold treatment. This is in your handouts. You just really need to think before you put somebody in the hospital there are a lot of burdens, infections you can get, treating a lot of stuff that you weren't planning on. So think about that. And lastly, so we move to comfort measures only or palliative care, the hospice approach. I'll tell you what, I won't take the time and go through this slides. It's really good, but I want to make sure we get, it's when we shift to preparing for this comfortable and dignified death. Palliative care is for anyone with a serious illness. You can get it and still get care to try to cure your disease. Any age, you don't have to be old. You don't have to have a terminal disease. But if you are having, your symptoms are burdensome, you can get palliative care. Hospice care is for people who are with months to live. You stop curative treatment and focus on making you comfortable at the end of life. Antibiotics is also something you can choose to withhold or withdraw. Always consider the possibility that life can be a burden and death a benefit. That picture I showed you of my family, my cousin called me one time as his mother was failing. And she had been in nursing homes, demented, she didn't know the family. And so they were whether to put her in a hospital for antibiotics. And I said, Bo, I'll tell you, I'll say this because you're family, but you know, sometimes death is a benefit and living is a burden. He said, you know, we thought the same thing and we just kind of wanted to hear you say it. So always consider that possibility. All right, we'll, I'll tell you what, I'm gonna skip through these great cartoons you're gonna have to miss, but the spiritual issues at the end of life. Those again are in your handouts. By the way, your handouts run for 17 pages. I wasn't planning on telling it. What it is, I had done a lecture in February. The last one I did before COVID shut everything down, and I was to a bunch of clergy. So there's a bunch of quotes in there that deal with the spiritual issues at the end of life. So just to encourage you, this is a really important part of approaching a peaceful death at the end of life. So, all right, Susan.
Thank you, Hank, so much. That was such a beautiful slide. The consider the possibility that life is the burden and death can be a benefit.
Yeah, some kind.
All of us that work in hospice, I think that this is something that we really take to heart, and it's one of the most difficult things for families sometimes to understand, because we live in culture that generally believes that life at all cost is better than death in any way that it can present itself. I'd love to invite you back, actually, maybe just for a session on the spiritual burdens and the spiritual benefits
Sure.
of these kinds of conversations. So I'm booking 2021, so you're on our list.
Yeah, that thing I was doing with the clergy in North Carolina was an all-day 6-hour event.
Wow.
So, but I can do an hour and a half on the spiritual issues. So yeah, be glad to do that.
Well, we have about 5 minutes left, and I just want to make give an opportunity to people that may have a question that they weren't able to ask earlier, or a question that's just presented itself. And I see Nancy has her hand up. Just a reminder to those of you that want to share, bring your cursor either to the top or bottom of your page, click on the participant button, and there'll be an opportunity to raise your hand like that. Nancy, could you unmute yourself, please? And let me see. Yes, you are set to unmute yourself. Thank you.
Yeah.
1 second, Nancy. Let me just see.
Okay, I'm in.
You're
Thanks.
good.
So I have a question about suctioning. And when I look at the handout, it talks about artificial hydration. Withholding artificial hydration will be the result of less fluid in the throat, less suctioning. So my question is, when is suctioning okay? Or what is your opinion around when to do it?
Oh, suctioning, in my view, is always okay. And, Susan, are you a nurse? I can't remember. maybe there's some nurses and
No,
doctors
but I
on
played
here.
a doctor once, but we,
Okay, well,
no,
please,
but we have a
somebody,
nurse.
if I don't do well on this, then one of you medical people help me here.
Then I will ask Shelley Saltpeter to give us her opinion about that.
Yeah, okay, suctioning's always okay, but you get fluid in your throat and it's hard to breathe. They can stick a tube down there and suction out fluid that makes it easier to breathe. So it's a comfort measure. It's not painful. It can, like I said, it can clear it out. Other things that are comfort, oxygen, morphine for people who are having difficult breathing can relax and can breathe either. So a lot of times people will get morphine and it makes it easier for breathing too. So the principle is we want the patient to be comfortable and we're promoting their comfort. And giving an antibiotic to try to get them over pneumonia does not necessarily make them more comfortable, but it might prolong the dying process. But giving them oxygen to help them breathe easier, or morphine to ease the breathing. So is that helpful?
Yeah, you know, the reason I asked is that my train of thought was that families want suctioning because they're uncomfortable hearing their loved one
Sure.
gurgle, but then I thought I had been told that it actually was painful to the patient and it was really just to benefit the family. You know, you've heard of the death rattle or.
Yeah.
Okay.
Maybe our
That's
physician.
good clarification.
Yeah, go ahead. Can you speak up unmute yourself and give the doctor's view on this?
Hi, I'm Shelley Saltpeter. First of all,
Hi,
I wanted to say, Hank, thank you so much for your book. I have bought several hundred copies over the years.
Yeah.
Thank you.
10 years ago, I would email you and say, Hank, I need another 150 copies, and you would mail it to me in a nice little box, and I would get all of my stuff. What I really like about it, it's a very nice combination of good medical facts in addition to the spiritual concept of goals of care and comfort and happiness. And I thought that it was just such a wonderful, wonderful addition to my job that I just wanted to thank you personally.
Thank you.
In terms of the suctioning, I'm personally not a great fan of it, especially when they kind of go deep down into the throat where they're gurgling. So once they really are getting to be relatively imminent, they do have this gurgling of oral contents back in their throat that the suctioning cannot get. So what I tend to do is try a little bit of like Atropine nebulizer, which can kind of dry up the secretions, and then use the sponge, that sort of pink, blue sponge thing that you can add with water. And then also do teaching about the gurgling. So suctioning isn't great in my, opinion, but oftentimes it's something that they really want, especially if there's nurses or doctors who have been involved with the patient in the hospital, and all the nurses have been doing suction. Oftentimes it is sort of a struggle, and they really want to get that suction machine at home. But anyways,
Yeah.
that was my.
Thank you.
Anybody else have a question before we wind up? One last question. Thank you so much, Shelley, for clarifying that.
Thank you. Yeah.
I think there's one question maybe in the chat. Hank, somebody was asking if you would feel comfortable sharing what changes you've made to your living will. I believe this was the question. What would you, if there's anything you'd like to share, I think this was in response to talking about having your advance directive changed a number of times.
I would, yeah. I actually, I didn't change the piece of paper because, as I said earlier, my living will, it's very general. If I have a life-threatening illness, I don't want anything artificially prolonged, including no hydration, nutrition. I think I did specify that because a lot of states require that. No, so when COVID first started happening, and I'm 72, and I've got diagnosis of asthma. And so it seemed that some people were going on a vent and coming off of them, a lot of old folks. And so I've kept up with the research on this, and as the months went on, this is my reading, and you can do your own research on this. But two things happen. One is if I'm bad enough at my age and my diagnosis to need a ventilator, it can be long and drag out, and there are long-term negative consequences on my quality of life. And I then tell my wife I don't want to be on a vent, no CPR, no vent if I get COVID. The other thing that has happened that has been good is they're finding other ways of treating shortness of breath, short of ventilator support. Proning, they call it. You put the patient on their stomach. Other things they've done that treat the shortness of breath short of going on a ventilator. So that's my, and again, Shelley, maybe you can, I don't know if you work with COVID respiratory failure patients or not, but that's what it was for me. Now the point in this discussion is talk to your power of attorney if you want to make changes about this type of stuff. You don't have to go and do another document. That's why you have someone to speak for you, is keep updating it. I just wrote a blog piece about that. I mentioned about that podcast, and I says, you know, this Thanksgiving around there, you can, you know, tell your family again. And I says, I can hear your family now. So, oh, Mom, do we have to go through this again? So, but keep talking about it. If you change your mind about stuff, but just make sure your family knows the latest of what you want. So, so that, again, don't take my advice. By the way, these medical journals, if you go to them and you want to get a whole article, sometimes they're $35 or $50 just for one article, but they have all made these COVID articles for free. So you can go to JAMA or to New England Journal of Medicine, JAGS, they have, during this whole pandemic, make their research available to everybody for free. So if you're really interested in that, go to these different websites and you can get the latest information and make your own decision on that stuff. And talk to your own physician about it.
Hank, thank you so very much. I've been so, somebody that, you know, considers these things often and regularly. It's just wonderful to see this information laid out in this way. And it's such a wonderful compliment to our Take Charge training that we also offer. And thank you so much for starting your talk with the website Mission Hospice, which will be included. I really appreciate that. No, I did not ask Hank to do that.
He didn't ask me to. I put the slides up before she even said it. So no, it's really good. It's good stuff. So
I just want to thank everybody. I will be sending an eval and a resource list to you all this afternoon is my goal, possibly tomorrow morning. It's so helpful if you're able to complete the evaluation. It's virtual. It will take you less than a minute probably to click through it. It really helps support our program here at Mission Hospice and Home Care. Hank, I will be in touch to book you for next year in the first quarter, January, February, or March, and we can talk specifically about spiritual care and ethical dilemmas around these decisions. For all of us that work at hospice, at Mission Hospice, we really thank you. For all of you that are on this call, from other healthcare organizations, other hospices, and from the community, please know that we're a resource for you, and you can reach me by email, and we always try to connect you to the best resource for yourself. For those, I know that hospice was mentioned a number of times during this, and I want to also just say, because some people just don't know this, in the United States, because we have people from other countries with us too, but in the United States, anybody that works gets a portion of their paycheck taken out for SDI and for Social Security, well, and for Medicare. The hospice is a Medicare benefit that you have already paid for. And so when I hear of our patients that come in for service and have, you know, 1 or 2 days on hospice, I always am like, oh my God, you've saved your whole life for like this trip with all these people to help you. And you're only using 2 days or 1 day of that. So I encourage people as early as they can get into hospice to try it out, because it's so easy to get off of hospice. You just sign a piece of paper if that's not the way that it might feel right for you to navigate your illness. So thank you so much. And yes, Santu, we'll ask when he's with us for our spiritual discussion about these decision-making processes, and if he can talk about the guilty family member feelings. I'm sure, just like there's a daughter from California, there's a guilty family member person also always. So I want to thank you all. There'll be a lot of resources, and you'll be all getting next week an email blast from us about our upcoming talks. Barbara Carnes, who is a nationally and probably internationally known hospice nurse for the last 32 years, will be speaking on October 29th from, I think, 2 to 3:30 for us. She's remarkable. Her work with people that are dying and her ability to translate complicated ideas into very simple things to understand is extraordinary. She was also the very first presenter I presented in 2015, about 4 weeks after I started my job at Mission Hospice, so I'm happy to have her back. So thank you all. Thank you for staying as long as you have. I'll be on the call for a couple of minutes after people start to leave if you have any questions that I can help you with. Hank, if you are able to stay for a couple of minutes, and if you can, I totally understand that it's later in Mississippi than it is here in California. So thank you all so much for joining us. Bye-bye.
Goodbye.